Josh Melson from Rush University Medical Center. I'm here to discuss our paper in gastrointestinal endoscopy. The presence of small sessile serrated polyps increases the rate of advanced neoplasia upon surveillance compared with isolated low-risk tubular adenomas. This is an important contributor to interval cancers. Their pathogenesis arises from a molecular pathway that is distinct from conventional tubular adenomas. There tends to be CIMP positivity of the CpG island methylator phenotype, and they tend to account for a higher rate of interval cancers than is thought of as with tubular adenomas. The thought is that the consequent DNA instability in these polyps leads to a progression that is more rapid than in conventional adenomas, similar to that in Lynch syndrome. So the World Health Organization recognizes three types of serrated polyps. The hyperplastic polyp, the sessile serrated polyp, and the traditional serrated adenoma. And they are classified in 2012, for the first time, the United States Multi-Society Task Force on Colorectal Cancer recommended a categorization of low-risk sessile serrated polyps, that is those of 1 to 2 in number, or less than 10 millimeters, and those without cytological dysplasia. And this is the group that we investigated. And so, again, the aim of the study was to compare rates of advanced neoplasia upon surveillance in patients with initial low-risk sessile serrated polyps versus those that had low-risk polyps that were absent sessile serrated polyps. So the adenoma detection rate of our group has been characterized. There were 14 gastroenterologists for which we analyzed data. The adenoma detection rates were 22.2% to 44.7%. That's a reported rate of adenoma detection rates. Adenoma detection rate that's not inclusive of sessile serrated lesions. The serrated detection rate of our group was 2.4%. That is in line with other studies. It's clearly lower than what some specific gastroenterologists have reported, but it's in line with what other group studies have reported. So we divided patients into 4 groups. We had 66 patients in a low-risk adenoma group inclusive of sessile serrated polyps. We had, of course, a larger group, 370 patients with low-risk adenomas without any sessile serrated polyps. And we also had patients in our high-risk adenomas with and without serrated polyps. Really, the primary finding, I think of most importance, is that the rate of advanced neoplasia upon surveillance in the low-risk adenoma group, when it was inclusive of a sessile serrated polyp, was significantly greater than when you have a low-risk adenoma group and there is no sessile serrated polyp. So it was 18% rate of follow-up or metachronous advanced neoplasia in this low-risk group with inclusive of a sessile serrated polyp, and the rate of advanced neoplasia on the follow-up was 7.8%. The demographic characteristics were roughly similar between the group. There was somewhat of a disposition towards women and smokers in the serrated group, as has been seen in the literature prior. In fact, the rate of advanced neoplasia in the small sessile serrated low-risk group of 18% was similar, actually slightly higher than in the in what would be considered a conventional high-risk group of advanced neoplasia, when we think of advanced neoplasia as a polyp greater than a centimeter, the presence of high-grade dysplasia or villous features. That rate was 15%. So, the conclusions are that while the USMTF treats these small sessile serrated polyps of 1 or 2 as essentially similar currently to conventional adenomas, it appears that they do carry a higher risk based on our experience of having advanced neoplasia upon surveillance, and that there should be a reconsideration of the importance of this group. There are some limitations of our study, so we're definitely underpowered here to make any comment about the actual colorectal cancer risk in surveillance. There's always an issue with concordance between pathologists. There can be an interpretation of hyperplastic and serrated polyps differing amongst pathologists. We did look at inter-observer variability amongst our pathologists and found a minimal rate, but generalizability in terms of that issue is always an issue when doing studies on sessile serrated polyps. Future, it'll be interesting to have prospective studies that look at these sessile serrated polyps, both in their type and in their burden and size, and looking at advanced neoplasia on surveillance. Thank you for your time.